You're listening to Who Said, a cardiology board review series. No fluff, just facts.
This episode is about single ventricle. We'll talk about physiology of univentricular diseases, repair, and then end with post-repair issues. What are univentricular heart defects? This is a condition in which there is only one functional ventricle, even if there are physical remnants of two ventricles, which can either be of a LV or RV morphology. It is very rare to have an anatomic solitary ventricle. Usually, there is unbalanced ventricular mass consisting of one large ventricle and one rudimentary ventricle. This single ventricle must sustain both the systemic circulation and pulmonary circulation, which are not connected in series at birth, but rather in parallel. Because of the parallel circuit and univentricular physiology, the oxygen saturation of the systemic arterial blood is reduced and there's a chronic volume overload on the single ventricle. If this goes untreated, there will be progressive ventricular dysfunction, pulmonary vascular dysfunction, pulmonary hypertension, and congestive heart failure. The most common examples of univentricular heart defects are these four. 1. Tricuspid atresia leading to single left ventricle. 2. Double inlet left ventricle, DILV, with rudimentary right ventricle. 3. Atrioventricular septal defect with common AV valve and hypoplastic left ventricle. 4. Single right ventricle as seen in traditional hypoplastic left heart syndrome. What is the physiologic impact of univentricular heart? First, consider normal circulation, then shunted palliation, then Fontan circulation. In normal circulation, the pulmonary circulation is connected in series with the systemic circulation. The right ventricle provides enough force for the blood to pass through the pulmonary resistance, and the right atrial pressure is lower than the left atrial pressure. In univentricular heart defects, the systemic and pulmonary circuits are connected in parallel, both emptying into the single ventricle, causing volume and pressure overload of that ventricle. Because of complete mixture of systemic and pulmonary venous blood, the blood in the single ventricle and the entire systemic circulation is mixed or desaturated. When Fontan repair is performed, the superior vena cava and an inferior vena cava are connected to the pulmonary artery without a subpulmonary or systemic atrium. The lungs thus become the main limitation to flow in Fontan repair. In the absence of fenestration, there is no mixture of systemic and pulmonary venous blood, but the systemic venous pressures are markedly elevated. A fenestration allows the systemic venous blood to bypass the Fontan portal system, thereby increasing output and decreasing congestion, but also decreasing arterial saturation. Let's talk about repair of single ventricle. There are three main steps. Repair step 1 is to think about what are the types of pulmonary flow modification. Repair step 2 is either a Glenn or bidirectional Glenn surgery. And repair step 3 is either a classic Fontan or a direct RA-to-PA Fontan, a lateral tunnel Fontan, or extracardiac Fontan. So let's start with the first step. What are the types of pulmonary flow modification? To survive the neonatal period, infants with univentricular physiology need to be protected from excessive pulmonary flow and also must have adequate pulmonary flow. 80% of univentricular infants need one of the following procedures. In patients with decreased pulmonary flow, augment pulmonary flow by creating a systemic pulmonary shunt. In patients with decreased pulmonary flow, there will be cyanosis because the blood cannot go to the lungs to get oxygenated. They should be given a systemic pulmonary shunt. For example, between the subclavian artery and ipsilateral pulmonary artery, modified Blalock-Taussig shunt. In patients with increased pulmonary flow, reduce pulmonary flow by banding the pulmonary artery. In patients with increased pulmonary flow, pulmonary hypertension and heart failure can develop. That's why you need to band the pulmonary artery. Repair step 2. What are the types of Glenn surgeries? First, the classic or unidirectional Glenn surgery. In 1958, Glenn introduced the practice of shunting the superior vena cava to the right pulmonary artery, where the right pulmonary artery was cut and it was anastomosed to the right side of the superior vena cava after ligation and division of the azygos vein. The superior vena cava was then ligated at the cavo-atrial junction. This means that the right pulmonary and left pulmonary artery are no longer in communication with each other. Unfortunately, late deterioration occurred in these patients because of decreased effective pulmonary blood flow resulting from the development of systemic venous collaterals and pulmonary arteriovenous malformations. The increased venous pressure to the lungs caused systemic collateral vessels to develop and shunt blood away from the pulmonary artery. The pulmonary AVMs were initially attributed to lack of pulsatile flow, but later found to result from the exclusion of hepatic venous flow from the pulmonary circulation. Now, how about bidirectional Glenn surgery? In 1989, the bidirectional cavopulmonary shunt was devised. This involved anastomosing the superior vena cava to the right pulmonary artery. This allowed the left and right pulmonary arteries to remain in continuity because the right pulmonary artery was not cut. This improved systemic arterial oxygen saturation without increasing pulmonary vascular resistance. Although the incidence of pulmonary arteriovenous malformations and systemic venous collateral vessels is not as high as in unidirectional Glenn, it is still present in bidirectional Glenn, so the patient should be sent to Fontan surgery when possible, generally before 2 years of age. Repair step 3. What are the types of Fontan surgeries? Classic Fontan. Francis Fontan in 1971 devised a way to separate the systemic and pulmonary circulations by connecting the systemic venous return to the pulmonary arteries without interposition of a pumping chamber. Specifically, the IVC is connected to the left pulmonary artery after a preceding classic right Glenn procedure that connected the SVC to the right pulmonary artery. Residual postcapillary energy is used to push blood through the lungs with near normalization of the arterial oxygen saturation and elimination of the chronic volume overload on the single ventricle. However, because there is no pumping chamber propelling blood through the lungs and because there continues to be pulmonary impedance, this creates a state of chronic congestion in the systemic veins and eventually venous hypertension. Since the blood is pooling in the systemic veins and there is limited postcapillary energy, the cardiac output also declines. This is the root cause of almost all long-term physiologic impairments and complications of the classic Fontan circulation. Next is the direct RA-to-PA Fontan. This direct right atrial to pulmonary artery Fontan was used specifically for patients with tricuspid atresia. This operation involved closure of the atrial septum and anastomosing the pulmonary artery to the right atrial appendage. Because the right atrium is not accustomed to receiving the higher pressures of the pulmonary the way that the RV is, this would often lead to marked dilation of the right atrium, which would then lead to thrombosis and atrial arrhythmias. Therefore, the atrial pulmonary Fontan has now been abandoned. You will encounter at most a handful of patients that still have this. Next is the lateral tunnel Fontan. The lateral tunnel Fontan, which is no longer as common but used to be one of the widest in use, involves routing the IVC and hepatic veins through the right atrium using the atrial wall as part of the tunnel wall and anastomosing directly to the pulmonary arteries. This is done with an intentional fenestration in the wall of the tunnel in the right atrium, enabling a small right-to-left shunt and mild systemic desaturation. Then we have the extracardiac Fontan. That's the current favored one. The extracardiac Fontan involves a conduit placed outside the heart, routing the IVC and hepatic veins directly to the pulmonary arteries. This is preceded by a superior cavopulmonary anastomosis called the bidirectional Glenn operation, which is an end-to-side anastomosis of the SVC to the right pulmonary artery. One benefit of the extracardiac Fontan is that it minimizes the need for extensive atrial sutures, reducing the risk of future atrial arrhythmias. In addition, the extracardiac Fontan can be performed off bypass. So those are the 3 main steps of repair of single ventricle physiology. How about post-repair issues? Because of chronically elevated systemic venous pressures and low preload to the single ventricle, there will be an inevitable state of Fontan failure. This can manifest as advanced liver damage, atrial arrhythmia, protein-losing enteropathy, lower extremity venous congestion, and diminished exercise capacity. Fontan-associated liver disease, or FALD, results from chronically elevated central venous pressure and chronically diminished cardiac output. Fontan-associated liver disease will start with fibrosis, followed by cirrhosis, and in rare cases, hepatocellular carcinoma. Fontan patients require regular liver imaging and biomarker surveillance. Hemodynamic abnormalities in the Fontan system may first manifest itself as an arrhythmia, so any arrhythmia should warrant careful assessment of the Fontan circulation and ventricular function. Note that 60% of adult Fontan patients will have sinus node dysfunction and atrial arrhythmia, including intra-atrial reentrant tachycardia or focal atrial tachycardia due to the extensive atrial scarring from Fontan surgery. The 2018 Congenital Heart Guidelines say, catheter ablation can be useful in adults after Fontan palliation with intra-atrial reentrant tachycardia or focal atrial tachycardia. That's a Class 2A recommendation. Fontan revision surgery, including arrhythmia surgery as indicated, is reasonable for adults with atrial pulmonary Fontan connections with recurrent atrial tachyarrhythmias refractory to pharmacologic therapy and catheter ablation who have preserved systolic ventricular function and severe atrial dilation. That's a Class 2A recommendation. Atrial arrhythmias and Fontan repair require chronic anticoagulation. Warfarin is used because the large-scale data on DOACs are still lacking in Fontan patients. The 2018 Congenital Heart Guidelines say anticoagulation with a vitamin K antagonist, such as warfarin, is recommended for patients with Fontan palliation with known or suspected thrombus, thromboembolic events, or prior atrial arrhythmia and no contraindications to anticoagulation. That's a Class 1 recommendation. They make a weaker Class 2 recommendation for those without thrombus, thromboembolic events, or prior atrial arrhythmia as follows. Antiplatelet therapy or anticoagulation with a vitamin K antagonist, such as warfarin, may be considered in adults with Fontan palliation without known or suspected thrombus, thromboembolic events, or prior arrhythmia, Class 2B. If atrial fibrillation develops in Fontan repair patients, rhythm control is preferred over rate control. Regular surveillance with ambulatory cardiac rhythm devices is warranted. In addition to the usual expected side effects of bradycardia such as fatigue and reduced exercise tolerance, slow heart rates are detrimental in Fontan patients as it further reduces the preload in the systemic ventricle, further increases the venous pressure, and consequently decreases the cardiac output. If a pacemaker is needed, an epicardial pacemaker is usually the pacemaker of choice due to Fontan surgical anatomy. Serial echo, MRI, or CT should be used to assess systemic ventricular function, valvular function, flow in the Fontan pathway, and long-term sequelae of the Fontan circulation, including thrombosis, sources of right-to-left shunts, and any obstruction of flow in the branch pulmonary arteries. Fontan patients have an elevated risk of thrombosis due to the non-pulsatile nature of the system, especially in patients who had an atriopulmonary Fontan. Other than history of atrial arrhythmias, history of thrombosis in a Fontan circulation, or prior episodes of suspected embolic events warrant initiation of anticoagulation. Not infrequently, progressive Fontan failure cannot be detected on imaging and requires assessment by right heart catheterization to measure intracardiac pressures, evaluate collateral vessel burden, and evaluate other sources of shunts. Pulmonary vasodilators, including primary endothelin receptor antagonists and PDE5 inhibitors, can be used as they increase capacity. Specifically, the 2018 Congenital Heart Guidelines say pulmonary vasoactive medications can be beneficial to improve exercise capacity in adults with Fontan repair. That's a Class 2A recommendation. Aerobic exercise and strength training also improves flow in the Fontan circulation and improves exercise capacity. Although prognosis is not great, long-term survival has significantly improved post-Fontan. Univentricular patients post-Fontan have a 90% survival at 30 years of age and 80% survival at 40 years of age. The 2018 Congenital Heart Guidelines say reoperation or intervention for structural or anatomic abnormalities in a Fontan palliated patient with symptoms or with failure of the Fontan circulation may be considered. That's a Class 2B recommendation. That's all for single ventricle.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rahu.com/meded.